I would like to extend my warm welcome to our esteemed speaker and panelists for today's webinar, Dr. Suresh Advani. I think sir is here. Over to you, sir.
Hello.
Yes, sir, you are audible.
Hello, am I audible?
Yes, sir, you are audible.
Shall we start?
Sure, sir.
So, colleagues, today we are very happy that we have joined together to learn more about the gynecological oncology multidisciplinary team meeting. We are here to discuss one of the very important topics on the endometrial cancer. Endometrial cancer, as all of us know, that is one of the most curable disease. And the multidisciplinary approach, where the surgery and adjuvant radiotherapy and chemotherapy and nowadays immunotherapy plays a very important role. To discuss about all these things, today we have very eminent speakers with us. I must say that today we have Dr. Amita Maheshwari, and we have also Dr. Anuradha Mehta and Dr. Anbarasan Sekar, and also oncopathologist Dr. J. Mehta. And all these experts will discuss in detail about their importance in terms of controlling the disease. As all of you know, that immunotherapy and also the target therapy, or the demonstration of HER2 molecule, has become an important factor in the management of this disease. So let us now hear from the expert what they have to say and how we can learn more service to the patient.
Hi, a very good evening to all colleagues who are attending this lecture. So I'm going to start with the pathological kind of aspect of testing for endometrial cancer. Okay, sorry, this thing doesn't seem to be moving. Yeah. Okay, so things in endometrial cancer have moved beyond the microscope. The Cancer Genome Atlas studies have revealed that endometrial cancer can be divided into at least 4 distinct molecular subtypes, essentially based on the tumor mutation burden and the somatic copy number alterations. And these subtypes give you a lot of prognostic and predictive information. And we have moved beyond just the histomorphology alone to something tailoring towards the patient's individual needs. And these 4 subtypes, the first 2, that's pole mutations and the mismatch repair deficient tumors, have to do with the tumor mutation burden. They are extremely heavily mutated, versus the somatic copy number alterations, the copy number high subgroup being the P53 abnormal group, whereas the copy number low being the non-specific molecular subtype. It's important because the prognosis varies between the subtypes. For example, on the pole mutation, the prognosis is excellent, more than 96% 5-year survivals, versus the P53 abnormality group where it's poor, so just half of them survive at the end of 5 years. The mismatch repair deficient subgroup has intermediate prognosis, whereas the NSMP group or the copy number low group has intermediate to excellent prognosis. The excellent ones are those which are ER positive. The ER negatives tend to have poor outcomes. The treatment implications for these molecular subtyping for pole mutated tumors, you can actually de-escalate or just put the patient on observation, versus immune checkpoint blockade for MMRD patients. If it's ER positive copy number low subgroup, then estrogen receptor blockade remains possibility. And for the P53 abnormality group, it's chemotherapy versus also depending on which other biomarkers have come positive in that group, but typically requires chemotherapy and radiation for the P53 abnormality group. So this is the flow chart that you would kind of want to understand. You start by doing the pole mutation. That if that's negative, then you go to the MSI analysis. If it's deficient MMR, then nothing more needs to be done. If it's proficient or wild type, then you actually do the P53 analysis. If that's wild type, it falls into the no specific molecular subgroup. If it's P53 mutated, then it's just the P53 abnormality molecular subgroup. Now, the decision to apply this classification for all endometrial cancers, especially those that are high grade or high risk, depends on the resource availability and the decisions made by the molecular tumor board. A complete molecular classification, however, aids in assigning prognostic risk groups, screening for Lynch syndrome, also identifies factors influencing adjuvant and systemic treatment decisions, as well as predictive value regarding immunotherapy kind of treatments. Now, in early stage endometrial cancers, that's stage 1 and 2, the presence of pole mutations or P53 mutations actually results in downstaging or upstaging the disease. So that's important, and you do this according to the new FIGO staging, which incorporates surgical, anatomical, and histologic findings. In contrast, when you have advanced stages, that's stages 3 and 4, they're not typically modified by the additional molecular analysis. Now, in any case, pole mutant endometrial cancers are exceedingly uncommon in advanced stages. So coming to the pole, that's the ultra mutated subgroup. There are certain things on morphology also which can help you pick up this thing in terms of looking at the morphology. If you have this marked atypia, heterogeneity, or giant anaplastic cell, that's an indicator that this could be pole mutated. These tumors are overrepresented in undifferentiated or dedifferentiated carcinomas. And clear cell carcinomas and carcinosarcomas have very few pole mutations. This pole mutation results in the ultra-mutated phenotype, which means there are several neoantigens, and therefore there's a huge immune response in the form of tumor-infiltrating lymphocytes, and that's the reason that these tumors may respond or benefit from immunotherapy. Now, it's important to understand that pole mutations tend to cluster in the exonuclease domain, especially in conserved residues 286 to 411. It's important to understand this because there are just a list of about 11 pole exonuclease domain mutations that have been both genomically and clinically interrogated to confirm its pathogenicity, versus even other exonuclease domain mutations which are not necessarily indicators of de-escalating therapy, and they may still have inferior clinical outcomes and should not be considered for de-escalation. So the NGS report needs to tell you whether they are in that 11 defined 11 pole mutations. The most common ones are P286R and V411L. These account for about 80% of the pole mutations that you can discover. Now, per most current guidelines, including the NCC, and all early stage pole mutated endometrial cancers are designated low risk and may be offered no additional therapy. One should prefer NGS over Sanger sequencing because you need to check for these various different mutations. So Sanger sequencing would probably just take care of 1 or 2 together, but NGS will take care of all 11 together. Also, you would then be getting some information on the P53 and the MSI status also by NGS. So coming to the mismatch repair deficient subgroup, this accounts for about 1/3 of all endometrial cancers. And there are several pointers for histology, which you can, if you see this, there are very definite pointers that this subgroup or this endometrial cancer may belong to this MMRD subgroup. Tumors in the lower uterine segment, those with endometrioid differentiation, tumors with nuclear atypia, undifferentiated component, high index, mitotic index, high number of tilts, high morphologic heterogeneity, a little bit like how the pole mutation subgroups would look. These are all also pointers towards mismatch repair deficiency, substantial lymphovascular space invasion, deep myometrial invasion, and synchronous ovarian cancers, particularly if you have clear cell tumors or endometrioid variants. And there's a high possibility that this belongs to the MMRD subgroup. Again, it's more represented in the undifferentiated carcinomas, redifferentiated carcinomas, neuroendocrine carcinomas, although these are very uncommon in the uterus, and high-grade endometrial adenocarcinomas. There are very few in the clear cell carcinomas and carcinosarcomas. Grading does not matter in this subgroup. So if you have endometrial cancer which is MMR deficient, you don't need to grade it. The overall prognosis remains intermediate. There is currently a strong recommendation to assess the MMR status in endometrial cancers, and most guidelines recommend immunohistochemistry for analyzing this biomarker, primarily because it's widely available, inexpensive, and pretty fast, versus a PCR, which actually takes time and also requires, remember, a paired normal DNA sample of the patient, which may not always be possible to procure at the same time. Now, another advantage of IHC over PCR is that the loss of expression pattern provides information on the particular altered gene. For example, if you have a MLH1 loss, that's a guiding force for actually seeking out underlying Lynch syndrome. Now, if you have NGS, well, that obviates all of the above problems. In addition, it can also assess for TMB if you're using a bigger panel. Another test that you can use for MMRD subgroup is the MLH1 promoter methylation testing. It's a methylation-specific RT-PCR, and it's also performed on paraffin tissues. It's another relevant molecular testing technique used in MLH1 or PMS2 deficient tumors, because you need to assess for whether you want to rule out a germline mutation, which means it's a Lynch syndrome, or if it's a methylation, then it's not a Lynch and it's a somatic reason for losing the MLH1. There are specific conditions which might still require to do PCR or NGS instead of MMR protein analysis by IHC. And these are the kind of scenarios where you will actually need to do that. That's when IHC shows indeterminate, ambiguous, or equivocal results. You get false negative IHC results due to pre-analytic technical factors such as poor fixation. And sometimes the IHC shows aberrant patterns like cytoplasmic instead of the nuclear, or a dot-like or a perinuclear staining. These are all aberrancies in immunostaining. So you need to do an orthogonal testing either by a PCR, that's the MSI PCR, or NGS. Coming to the third subgroup, that's the P53 abnormal group. These have very low mutation rates, but they have high somatic copy number alterations. Amongst this, TP53 is present in about 90% of the cases, and therefore this group is named the P53 abnormal group. Now, majority of these tumors are high-grade serous carcinomas. You can also get them in carcinosarcomas, mixed endometrial cancers, and clear cell carcinomas. Now, these are all typically high-grade, except for the non-myoinvasive ones. The myoinvasive P53 abnormal endometrial cancers necessitate chemoradiotherapy. Also important to understand that these tumors might have homologous recombination deficiency, that's HRD, or HER2 overexpression or amplification, and these are good therapeutic markers. So assessment of P53 by IHC has a high concordance with P53 mutational status. So therefore, it's a good IHC surrogate to investigate for P53 mutation. There's such a thing as a subclonal pattern where a distinct geographic area of the tumor exhibits both abnormal and wild-type staining pattern. Why is it important to pick up this subclonal pattern? Because these are frequently associated with mismatch repair deficiency or pole mutations. So that's kind of a good triage to look for those mutations. Also, in these circumstances, when you have the mismatch repair deficiency or pole mutationals, then the P53 abnormalities lack its prognostic value, and the tumors have the better outcomes associated with MMRD or pole mutations. What about the no specific molecular profile? It's a diagnosis of default diagnosis of exclusion. So if you have absence of MMR deficiency, if you do not have any pathogenic pole mutations or a P53 abnormality, then that's the no specific molecular profile and falls into the TCGA copy number low subgroup. About half of endometrial tumors will fall in this subgroup. Now, these tumors encompass young women with low-grade indolent endometrial cancers, typically estrogen receptor expressing, which arise in the setting of obesity or excess estrogen production. And at the other spectrum, you have a thin, older women with rare histotypes historically categorized as high risk and an unfavorable disease trajectory. So in between NSMP, also you have one spectrum which does extremely well, and there's another spectrum which has unfavorable disease outcome, and these are particularly the ones which are estrogen receptor negative. Also for NSMP subgroup, one probably needs to look for L1CAM and CTNNB1 mutations. Now, L1CAM serves as an independent risk factor for locoregional and distant spread, and it's heavily associated with TP53 mutations, high tumor grade, and lymphovascular space invasion. It's a crucial indicator of high-risk disease, and its expression is most frequent in these P53 abnormal tumors. It predicts worse outcomes even among tumors the endometrial tumors which fall in the NSMP subgroup. And CTNMB1 exon 3 mutations prognosticate a higher risk of recurrence, particularly in the copy number low group. So even in NSMP group, it is worthwhile doing CTNMB1 exon 3 mutation analysis and L1CAM by immunohistochemistry, because these are significant prognostic biomarkers in this subgroup with clinical implications for deciding the adjuvant treatment. Now, there's a classification called multiple classifiers, and sometimes you do come across these kind of tumors. They're about less than 5%, but they combine more than one molecular feature of this molecular profiling. So you might have a pole mutation and a p53 abnormality, and a mismatch repair deficiency and a p53 abnormality. And these are then referred to as multiple classifiers. But it's intriguing to know that in tumors which have these dual mutations, this p53 becomes a secondary abnormality. And the current evidence indicates that they should not be classified as p53 abnormal because they retain the favorable prognosis of either the pole mutation or the MMRD deficiency. So it's important then to not make this out into the category 4, that's the secondary p53 abnormality group. Now, patients who have both pole mutations and p53 abnormality should be considered pole mutants, and if they have MMRD and p53 abnormality, should be considered only MMRD deficient subgroup. For tumors who have both pole mutations and mismatch repair deficiency, these are exceedingly uncommon and therefore the data are limited. And only good thing to come out of this is that you should look for an underlying Lynch syndrome. So what's the clinical utility of the molecular classification? You're going to do all these, and how does it really translate and help the treating physicians? So, for example, disease spread beyond the uterus is extremely rare in high-grade endometrial cancers which have pole mutations. So therefore, simple BSOH may be worthy for prospective evaluation. In contrast with women who have p53 abnormality subgroup, more aggressive surgery with lymph node assessment and omentectomy seems more appropriate. For young women who want to delay hysterectomy for reasons of fertility, a molecular classification could help guide further management. If you have a MMRD subgroup or a p53 abnormality category, this would discourage a conservative approach with progesterone therapy. Now, subsets of p53 abnormal high-risk tumors, at least a quarter of them tend to have HER2 overexpression, and about 20 to 40% might even have HRD. So these are excellent, biomarkers to use in this subgroup of endometrial cancers. Expression of L1CAM in this p53 wild type or the no specific molecular profile endometrial adenocarcinoma subgroup on curettage specimens might indicate the need to perform more aggressive surgery, because L1CAM tends to be associated with advanced stage, pretty similar to the p53 abnormality molecular subgroup, which also commonly express L1CAM, by the way. So to just wind up, molecular classification has profoundly changed the approach to endometrial cancer management with the emergence of biomarker-driven therapies, which is guided by diagnostic, predictive, and prognostic biomarkers. The integration of all these biomarkers as molecular tools in pathological reports represents a really new histomolecular concept for treating endometrial cancers. And this integration will enable the clinician to perform individualized risk stratification based on molecular profiles and define tailored treatment strategies. To just wind up, these are the WHO recommendations on the left side, which encourage you to do all of the testing, the pole, MMR, the p53 as well, and also by NGS. However, the British Academy of Gynecological Pathologists actually recommends something which is slightly more practical, and this stems from the fact that everybody doesn't have access to pole NGS testing. So they make the pole NGS testing optional for stage, that's a new FIGO stage 1A low-grade endometrial adenocarcinomas who do not have any lymphovascular space invasion, who are p53 wild type and MMR proficient, essentially meaning that these anyway are a low-risk category and therefore may not need pole NGS testing in any case. And stage 3 and 4 by the new FIGO staging, if those are the ones you can actually omit doing the pole NGS testing if the resources do not permit so. Thank you very much.
Good evening. Kindly share my slides. Hello. Yeah, thank you. Shall I go ahead?
Yes, sir.
Good evening, everyone. Thanks, Mehta sir, for this wonderful discussion on molecular base of endometrial cancer. Now we are managed. We all know that endometrial cancer is the sixth most common cause of cancer and 15 most common cancer overall in the group. And what we've seen is almost 4 lakh new cases diagnosed every year as per Globocon 2020 data. And almost 1 lakh cases of death has been seen with associated with endometrial cancer. Next slide. Next slide, please. Next slide. So there is, when it comes to endometrial cancer, there occurs a major disparity in the to stage 4 cancer. The survival rate is around less than 10%, higher overall survival rate. And how the staging has been classified mainly depends on two different factors. One is based on the depth of invasion, and second one based on the presence of metastasis is there or not. And currently, we're going to mainly focus on the stage 4 endometrial cancer person. Next slide. Next slide. What comes the major unmet need with respect to endometrial cancer? So molecular classification has changed the dynamics of 85%, whereas in stage 4 cancer, when it is metastasis there, even though response rates are there, the response rate were not long lasting. That's why the fire overall survival rate drops down to 17%. With arrival of GOG 209 in 2009, paclitaxel and carboplatin became the standard of care. After that, there has not been much change with respect to usage in metastatic setting till the arrival of immunotherapy into the scenario. When it comes to immunotherapy, we have multiple options that we are going to discuss in subsequent slide later. Next slide. Next slide, please. So patients, whenever they present with stage 4 cancer, they have high risk of recurrence. And this is because the disease become inoperable and they experience disease relapse quickly to first line of chemotherapy. And with GOG 209, which showed non-inferiority to compare to TAC regimen, and the median PFS around 13 months. They had a good response rate, but the recurrence rates are also quite higher. And we know that histology plays a crucial role currently in the era where the different histologies have various poor prognostic factor also, like clear cell carcinoma, mucinous, squamous cell carcinoma present in almost 20% of endometrial cancer. And these subtypes represent high risk group in this population. And we all know that in deficient MMR group, endometrial carcinoma, chemotherapy along with immunotherapy becomes the standard of care with approval of multiple line of regimen, starting from durvalumab, dostarlimab, atezolizumab, and pembrolizumab. And recently, durvalumab is also approved in deficient MMR based on the DOA study design. And all these four drugs has been considered whenever the patient is having deficient MMR, which constitute about 20 to 30% of endometrial cancer. And until the approval of pembro plus lenvatinib and doxorubicin monotherapy, most of the second line regimens were ineffective. We all know that second line regimen comes to endometrial cancer after platinum refractory setting. It is quite challenging, and pembro and lenvatinib is one of the options we often use for a second line setting, and dostarlimab monotherapy, but is not available in Indian setting. Next slide. So these are all the current standard of care with respect to the endometrial cancer. We have seen when we start with chemoimmunotherapy, if it is a the deficient MMR population, if it is proficient MMR population, we have combination of chemotherapy. When it goes to second line, we have option of immunotherapy along with TKI. Next slide. Next slide, please. This is the way in which immunotherapy has been evolved over a period of time in second line endometrial cancer therapy, starting from dostarlimab and pembrolizumab from 2015 to moving towards in first line setting also in combination with chemotherapy we have seen subsequently. In 2024, what we have seen is approval of immunotherapy, that is pembrolizumab, in deficient MMR as well as proficient MMR population also we have seen. In August 1, 2024, dostarlimab also has similar approval for proficient MMR population. Next slide. Coming to the important study by which second-line pembrolizumab plus lenvatinib has been approved, especially post-platinum-based chemotherapy regimen. This is a phase 3 randomized study design where 827 patients randomized into two different arms with pembro and lenvatinib is the study arm, and the control arm contains paclitaxel plus doxorubicin. The primary endpoint is a dual primary endpoint where the PFS and OS has been analyzed. Secondary endpoint include overall response rate and duration of response rate. Next slide. So here comes the updated progression-free survival with respect to proficient MMR group. It is 6. Previous slide, please. 6.7 versus 3.8 months, whereas in patients with final overall survival, 18 versus 12.6 months. There is a good amount of improvement in both progression-free survival as well as overall survival in proficient MMR population. This is one of the key options, especially when the patient having platinum refractory setting in this population. And the side effect profile is also slightly higher, 99 versus 99%, and grade 3 side effect close to 73%. Next slide. Next slide. Now we are going to discuss one of the important study, that is DOE, where we are going to see important characteristic feature of combination of chemotherapy of immunotherapy along with target therapy and chemotherapy in this population. So we all know that deficient MMR have been showing very good response with immunotherapy. The population we need to highly address and where the unmet need really exists is in the proficient MMR population. The concept behind combination of immunotherapy along with target therapy is mainly because that what we see with deficient MMR population is there is always tumor load will be there because of the destruction of population, because of the neoantigen load is always there. When we combine chemo with immunotherapy, this immune blockade will goes away. This able to act better effect of chemo and immunotherapy will be there. And we continue with immunotherapy, this will maintain the persistent blockade of persistently drive the immune blockade with the associated with the cancer directed therapy. When it comes to proficient MMR, the idea is we give chemotherapy along with immunotherapy for the population. Once the chemotherapy is stopped after 6 cycles, then we combine immunotherapy along with target therapy. This target therapy aids in producing some amount of tumor killing on the background, and this will activate the immune response in this population. This is the background behind usage of combination of immunotherapy along with target therapy in population with endometrial cancer. Next slide. So coming to the study design with DOA study design, patients were treatment naive have been selected into the study design, and those who were MMR status also been classified. And mainly those who are first line systemic treatment has been taken into the study design. One thing is, if the patient has taken adjuvant chemotherapy, then more than 12 months is the lapse time. So there have been different immunotherapy related studies design, as I mentioned earlier, that is NRG G18 study design, where they studied pembrolizumab, where the duration is also more than 12 months. Whereas with Ruby study design, dostarlimab, the duration is more than 6 months. And attend also it is 6 months. With DOE and NRG 18, the duration is at least 12 months between the adjuvant chemotherapy and the newer treatment enrollment into the study design. And all the histologies has been included into the study design, including carcinosarcoma has been included into the study design. Whereas the key difference here is NRG 18 study has not included carcinosarcoma into the study design. These patients will be randomized into 3 different groups. One is chemotherapy group, and other one is chemotherapy with durvalumab combination group, and third arm is chemotherapy along with durvalumab and olaparib into the study design. All these patients has been stratified based on the MMR status, disease recurrence status, and the geography of the population. They have been divided into 2 different phases. One is chemotherapy phase, where the patient receives 6 cycles of chemotherapy, and along with the based on the stratified arm, there is either durvalumab alone or durvalumab along with olaparib in the study population. And based on the response assessment, they will move on to the next phase, where they receive maintenance therapy. If they receive durvalumab in the chemotherapy phase, they continue with durvalumab. And if they receive durvalumab along with olaparib, if the third arm will contain durvalumab along with olaparib as a maintenance phase. And these are all the primary endpoint has been analyzed. Progression-free survival with respect to chemo plus durvalumab in comparison with chemotherapy arm. And the second arm contains chemotherapy plus durvalumab plus olaparib combination with respect to chemotherapy arm. And the key secondary endpoints include overall survival and safety analysis. Next slide. This is with respect to, next slide, please. This is with respect to the baseline characteristics. I would like to highlight 2-3 points in this slide. One is the population of MMR proficient is this 18%, close to the cancer genomic atlas data available. It is matching with it. And other thing is they measure the PDL1 status. Here the PDL1 status is based on the TAP score. So wherever the durvalumab has been used, the TAP score is the preferred way of PDL1 assessment. Even in gallbladder cancer TOPAZ study, they use TAP score only. Is total area positivity. If it is more than percent, it is considered as positive. And the PDL1 positivity is 68% in the population, which is uniform across the all three different terms. They also measure the homologous recombinant pathway mutation status, HRR pathway mutation status, not HRD status, and it is also similar across the all three different terms. They included the carcinosarcoma population also, and it is varies between 5 to 9%, which is similar across majority of the study group. And NRG 18 doesn't include carcinosarcoma into the study design. And the previous chemotherapy has been seen in 20% of population, previous RT close to 30% of population in the study design. Next slide. Next slide, please. Next slide. So coming to the after randomization, what will happen with respect to the treatment per se? The patients, after receiving the intended chemotherapy phase, either with paclitaxel carboplatin, paclitaxel durvalumab, when the starting of the maintenance phase, almost 70% patients were able to move on to the maintenance phase in the chemotherapy plus durvalumab. Whereas in chemotherapy plus durva plus olaparibam, almost 80% patients were able to migrate to the maintenance phase. Patients who still receiving treatment, close to 18% patient in the chemotherapy arm, it is 30% in the chemo plus durva arm, it is 40% in the chemo plus durva plus olaparib arm. And the median duration of chemotherapy cycle 6 across all the three different arms, and median duration of follow-up is 17 months duration. Next slide. Next slide, please. Coming to the primary endpoint with respect to the overall population, here what we are able to see is progression-free survival and overall survival endpoint. Coming to the progression-free survival, it is 61 months in the combination arm, that is chemotherapy, durvalumab along with olaparib, it is 61 months, and the response is holding up, it is 46 months. Whereas with respect to durvalumab alone, it is 48 months, and it is 34 months at the point of 18 months duration. Next comes to the overall survival. Overall survival, it is 87 months at the point of 12 months when the combination of Druva plus chemotherapy and olaparib has been used in the study design. And it is almost similar with respect to chemotherapy plus durvalumab combination in the study group. When it comes to hazard ratio, the hazard ratio is 0.71 in comparison with the chemotherapy arm when we used durvalumab in the study regimen. When they received Druva plus olaparib, the hazard ratio is still better. It goes up to 0.5%. We are yet to get the maturity data because the overall data maturity is only 61%. And with respect to overall survival, it is only 27% maturity has been achieved. Next slide. Coming to the subgroup analysis, with respect to subgroup analysis based on the MMR status, deficient MMR and proficient MMR population. In deficient MMR population, whether we use durvalumab along with olaparib or durvalumab alone, there is not much difference, especially with respect to hazard ratio. Here also the hazard ratio is 0.42. When the combination also durva plus olaparib, the hazard ratio is 0.4 only. It is almost similar. But the major difference happening with respect to proficient MMR population, here the difference is with respect to median PFS, it is 9.9 months with the single agent durvalumab arm, whereas the PFS improved almost 50% from 10 months to 15 months with respect to combination of Druva plus olaparib arm, and the hazard ratio is also 0.57 with respect to chemotherapy. With respect to durvalumab also, it is significant with the hazard ratio is 0.76. There is almost 25% reduction in with respect to usage of Druva plus olaparib with respect to durvalumab alone. This generates the data that in proficient MMR, probably the combination of Druva plus olaparib may tends to do better with respect to the combination proficient MMR population. Next slide. So what are the other endpoints which we are able to see with the difference in proficient MMR population? When proficient MMR population, when we use chemotherapy alone, the CR rate is almost 10%. When we use of immunotherapy, the CR rate hasn't much affected. Whereas when we use combination of chemotherapy along with olaparib, the CR rate is significantly better, which is close to 16%. And the duration of response rate also, with the combination of chemotherapy alone, it is 7.6 months. And chemotherapy plus durvalumab arm, it is 10.6 months. With the combination of durva plus olaparib, it is close to 19 months. Almost doubling of median duration of response is seen when we combine durvalumab along with olaparib in this population. With respect to the 24-month response rate, it is 37% patients still maintaining the response when they use combination of durva plus olaparib in this regimen. Next slide. Coming to the MMR subgroup population with overall survival. In deficient MMR, there is not much difference. The data is yet to mature. As I mentioned earlier, only 23% event happened with respect to the overall survival. When it comes to proficient MMR population, the hazard ratio is starting to separate. It is when we use combination of durva plus olaparib, the hazard ratio is 0.7. So there is some amount of differences there when we combine chemotherapy along with durva plus olaparib, and it is even in the earlier maturity of 30% also, it is showing the difference. And the difference is clear when we compare with chemotherapy, immunotherapy also, it is 0.75. Next slide. Other area I would like to highlight is the difference has been seen with respect to the proficient MMR population. The difference is significant with respect to PFS as well as with respect to overall survival also. Data start to separate as at least in proficient MMR population in terms of OS. The other area I would like to highlight is PD-L1 positivity. PD-L1 positivity has a significant correlation where there are all the three curves tends to be separated widely. When we use triplet combination, that is chemotherapy along with immunotherapy and target therapy, the 12 months progression-free survival is 70%, whereas 50% with respect to use of immunotherapy alone. With chemotherapy alone, it is only 40%. And the difference is maintaining over a period of time also at 18 months also, it is 54 versus 40 versus 21. And the hazard ratio with respect to PD-L1 positivity, it is 0.63 when we use durvalumab alone. When we use durvalumab, 42%. And when it combined along with durvalumab, it is 73% reduction. Is seen any statistical significance. Next slide. Coming to the forest plot with respect to the different parameters of analysis, PD-L1 expression has a good correlation. It favors combination of chemotherapy along with olaparib, and other factors like poly mutation or TP53 mutation. There is benefit is there, but it has not shown much significance. Next slide. Coming to the proficient MMR population, when we use PD-L1 score, the favor is much higher when it with respect to PD-L1 positivity, especially with TAP score more than 1%. And the difference is also significant when the patient is having TP53 mutant population, the hazard ratio is 0.47. These are the two different areas we need to highlight whenever the patient is having high-grade serous ovarian cancer, as well as patient who are having TAP score more than 1%, then we can consider for the population. Also, the difference is there. Look for HRD deficiency, it would have had much more benefit in the population. And with respect to histology also, it is showing benefit, especially when the patient is having endometrial or serous population. Coming to the safety profile, when we add multiple drugs, automatically the side effect profile is also going to be like on the higher side only, but most of the time it is manageable. With respect to the anemia, when we combine chemo with durvalumab, it is 50%, and the chemo with durva plus olaparib combination, it goes up to 60%. And the alopecia rate, otherwise it is similar. Other things, neutropenia risk is more or less similar, 22 versus 27%. And immune-related side effects wise, it is not, there is no higher increase in the immune-related toxicity when we combine immunotherapy along with olaparib in the study population. Next slide. So I think I would like to conclude over here with respect to the time. These are all the other studies which are ongoing with respect to deficient MMR population. They are even trying to exclude chemotherapy in the population, like dostarlimab in farm, but whether it's beneficial or not. The really is in with respect to the profession environment, especially when we see the TAP score as well as other key risk factors like TP53 mutant population. This is showing benefit, but data is yet to mature. We need to see much more better data to incorporate into the clinical practice. Thank you for this opportunity. Thanks, everyone.
For next session, I would like to invite Dr. Anuradha Mehta, who is assistant professor from Tata Hospital. She will throw some light on management of HER2 positive gynecological cancer. Over to you, ma'am.
Am I audible?
Yes, ma'am.
Hi, good evening, everyone. Thank you for inviting me. I'll briefly touch upon this topic. I hope my slides are visible. I'll be speaking on the management of HER2 positive gynecological tumors, the evidence which we have, and the subtypes for which we are using the anti-HER2 agents. So, just briefly touching upon the epidemiology, we very commonly see gynecological cancers in which the cervix remains the most common one, followed by ovary and endometrium. Coming to the HER2, which is a transmembrane receptor of hello.
Yes, ma'am. You're
Am
audible.
I audible? Yeah, sorry. Okay, so coming on to the HER2 receptor, which is part of the HER family, which is a transmembrane receptor, which has, when activated, leads to intracellular signaling pathway. And in our practice of breast cancer, colorectal cancer, other cancer where we have like gastric cancer, ample evidence that targeting HER2 agents, it has now moved on from those cancers with very good evidence in improving the survival to gynecological cancers also. So the alterations which we see in HER2 they could be overexpression, amplification, and mutation. So the frequency of HER2 alterations across tumor type, it varies depending on the site. Like it is earlier evidence which came was from breast cancer, and if we see depending on the IHC markers of scoring of 1+, 2+, and 3+, we have amplification and mutations also now available with us. And here we can see that in uterine cancers, ovarian cancer, cervical cancer, there is quite a number of patients which have HER2 overexpression when tested by IHC. This is one evidence of HER2 overexpression in gynecological cancers based on the histiotype. So in endometrium, if we see the serous endometrial subtype can have an overexpression or amplification of up to 49%, followed by carcinosarcoma, which can range from 7 to 25%, and followed by clear cell, which is 6 to 30%. For ovarian, the more common type which is associated with HER2 overexpression remains the mucinous subtype. And in all adenocarcinoma of cervix and gastric type adenocarcinoma, we may find HER2 overexpression. So coming on to the diagnostic testing for HER2 in gynecological cancers, there is no disease-specific HER2 grading criteria developed for. So there are disease-specific criteria for breast and gastric as per the ASCO and GAP guidelines, but there is no single widely accepted gynecological specific criteria. We usually extrapolate that from gastric only, and different trials have used different scoring systems, like 2007 breast, 2013 breast criteria, 2016 gastric, and 2018 breast criteria. So if we see, this is a slide showing the HNE on the left side of uterine serous carcinoma with on the B slide a strong circumferential HER2 staining. The lower left slide shows the mucinous ovarian carcinoma, and the D slide shows the strong basolateral HER2 staining so there is a difference in the circumferential and the basolateral staining, which is the this comparison which I'm showing now. So in the trials have used different criterias. As you can see on the left side, the phase 2 trial of trastuzumab and uterine serous carcinoma done in 2018 used the 2007 criteria. The Destiny Pan tumor, which we are going to now discuss, and the Status trial, which is a phase 2 trial of endometrial carcinoma, that used the 2016 criteria. The main difference of these being the percentage of cells, 30% versus 10% of the tumor, and the difference of circumferential versus the basolateral membrane staining. Now there are emerging HER2 directed therapies and combination therapies which I'll be discussing. There are not very strong phase 3 randomized controlled trials which guide us, but there are a lot of trials which are ongoing. The first evidence could be there are different HER2 anti-HER2 agents which are like tyrosine kinase inhibitors, monoclonal antibodies, and now the newer ADCs. Starting from the tyrosine kinase inhibitors, the HER2-directed TKIs, they compete with the ATP at the intracellular catalytic domain. Thereby, they block the phosphorylation and the activation of downstream signaling. The first TKI, anti-HER2 TKI, which was tried was lapatinib. However, in 2 phase 2 trials, it did not show any response rate, and in another trial, there was a response rate of only 3%. Niratinib is one irreversible inhibitor of EGFR, HER1, HER2, and HER4, which causes the arrest at the G1S phase. There was a basket trial known as Summit trial in which the niratinib showed a overall response rate in the range of 25% in the cervical cancer patients. And in such patients, the HER2 by IHC was not reported for these patients. However, it was seen retrospectively, and they concluded that HER2 amplification did not confer any additional sensitivity to niratinib, and hence it is not being used in clinical practice. There is one ongoing phase 1/1b Innovate trial which seeks to investigate the activity of combined niratinib and niraparib in advanced solid tumors with dose expansion in platinum-resistant ovarian cancer. These are the trials of HER2-directed therapies with some result in gynecological cancers. The lapatinib and niratinib TKIs I have already discussed have not shown much benefit. There is one phase 2 trial which was done in July 2018, which was the first evidence of using trastuzumab along with chemotherapy in treatment naive and recurrent cancers, uterine serous basically. This was the basis of our of use of trastuzumab in recurrent endometrial cancers, which I'll be discussing. There are also trials of zanidatamab, trastuzumab, duocarmazine, DB1303, and BDC molecule plus minus nivolumab. There are very few trials which are of these combinations which have shown benefit in overall response rate, which we'll be discussing. So coming on to trastuzumab, it is a monospecific antibody, binds the epitope in the extracellular domain of the HER2 receptor and impairs the receptor dimerization. It leads to HER2 endocytosis followed by antibody-dependent cellular cytotoxicity, causes the G1S phase cell cycle arrest, and increase activity of PTEN with more pronounced inhibition of the PIK3K pathway. So this was the trial done by Fader in July 2018. It was a phase 2 trial of paclitaxel carboplatin versus carboplatin paclitaxel with trastuzumab in uterine serous carcinomas. And it was seen that in 30% of the patients, HER2 was overexpressed. And patients of both primary and recurrent HER2 positive stage 3 and 4 patient, all stages were included, but maximum patient on doing the subgroup analysis, maximum benefit was seen in stage 3 and 4. They incorporated the use of trastuzumab along with chemotherapy for 6 cycles followed by trastuzumab till maintenance till progression, and they showed that the median PFS improved by 5 months in all patients, and on the subgroup analysis they concluded that the patients with stage 3 and 4, they got the greatest benefit, and the PFS was in the range of 8.4 months. They also showed that there was improvement in the overall survival also. And in the control arm, there were the overall survival was in the range of 25 months, and it was not reached in the experimental arm with trastuzumab. Coming on to the next anti-HER2 agent, which is pertuzumab. So the difference between the both agents is that trastuzumab binds to the subdomain of the HER2 receptor number 4, and pertuzumab binds to subdomain number 2, and it sterically blocks the homo and heterodimerization of the receptor. There is an ongoing we have ample evidence from breast cancer that pertuzumab in combination with trastuzumab and taxanes leads to overall survival in metastatic disease and also in neoadjuvant setting. There is now in gynecological cancer a randomized trial phase 2 and 3, which is going on in carcinosarcoma and serous carcinoma using the 2018 CAP breast criteria to define the HER2 positivity. And it seeks to evaluate the combination of paclitaxel with trastuzumab plus minus pertuzumab. Now moving on to the main drug, which is the antibody drug conjugate. These are the newer molecules which consist of an antibody and a cytotoxic drug, which is called the payload, and it is connected via a linker. They have three parts, as I told you: tumor specific antigen, which has a cytotoxic payload via a linker. This linker can be cleavable or non-cleavable. Trastuzumab deruxtecan utilizes the trastuzumab antibody backbone, which is conjugated to an exatecan derivative, which is a topoisomerase 1 inhibiting payload. So this binds to the trastuzumab, the antibody binds to the receptor, and there is then the antigen, then it forms an early endosome, then a late endosome, and then the lysosome. There is drug release from the cleavable and non-cleavable linkers. The unique feature of trastuzumab deruxtecan is that it also has a bystander effect, and the antibody to drug ratio is also higher, which is 8:1, and hence there is ample evidence now from breast and other lung cancers that it is a superstar molecule and has now effect in gynecological cancers also. So coming on to the main trial, which we are here to discuss, the Destiny Pan Tumor 02 trial. It is an open label multi-center phase 2 study. It included advanced unresectable and metastatic biliary tract cancers, bladder, cervical, endometrial, ovarian, pancreatic, and other solid tumors, excluding breast, colorectal, gastric, and non-small cell lung cancer, in which we have data of improvement of overall survival. And in this trial, HER2 IHC 3 plus and 2 plus was scored using the ASCO-CAP guidelines as per the gastric cancer scoring guidelines. The primary endpoint being the objective response rate, and defined as the proportion of patients with the confirmed complete or partial response by the RACIS criteria. And there were also secondary endpoints of duration of response, disease control rate, PFS, overall survival, and safety. So the patients of endometrium, cervix, and ovarian cancer, which were included in the Destiny Pan trial, were around 40 each, and the patients were they were of good performance status, and they were had HER2 testing, and the ones with HER2 2 plus were maximum in the range of 60%, and patients with HER2 3 plus were in the range of 40%. So the patients who had there were patients who were previous treatment were allowed, and if we see the overall response rate, they were very good in cases of endometrial cancer in the range of more than 80%, 84%. In cervical cancer, the results were very good. Overall response rate were around 75%, and in ovarian cancer also they were around 63%. These were the PFS curves of endometrium, cervix, and ovary, and if we see that the median PFS was not reached in endometrial cancer patients who had a IHC score of 3 plus of HER2. It was around 8.5 months in 2 plus, and the total was around 11.1. Similarly, for cervix and ovary also, with higher the IHC score, the PFS was higher. In the endometrial cohort, 77 majority patients had received 2 or more prior lines of therapy, and the overall response rate was 84%. And in all patient, median PFS and OS were 11 and 26 months respectively. Coming to the cervical cancer patient cohorts, 85% of them had received more than 2 prior lines of therapy, overall response rate being more than 75% in patients who had a IHC score of 3+. And the overall survival in this cohort was 13.6 months in all patients, not reached in IHC 3+, and 11.5 months in IHC 2+ patients. In the ovarian cancer cohort, the median number of prior treatments was 3. 35% of the patient had received 5 or more lines of therapy, overall survival being 13.2 months in all patients and 20 months in patients with a HER2 IHC expression of 3+. So leading to the integration of TDXD into this trial led to the integration of TDXD in the NCCN guidelines for recurrent HER2 2+ and 3+ endometrial, cervical and ovarian cancers, and also contributed to the accelerated FDA approval of TDXD for 3+ solid tumor based on the agnostic criteria. And though Destiny trial used the gastric scoring system, neither of these guidelines of FDA or NCA, they specify a scoring system required for the determination of HER2 positivity. Coming to few newer agents, trastuzumab duocarmazine is a targeting ADC which conjugates a DNA alkylating duocarmycin payload to trastuzumab. And in phase 1 trials of endometrial cancer patients, an overall response rate of 39% and median PFS of 4.3 months has been observed, and it has the common adverse events of ocular toxicity. Phase 2 trial is ongoing in HER2 IHC 1 or more in endometrial cancer. Another drug is disitamab vedotin. It utilizes a novel disitamab, also referred to as hertuzumab antibody backbone, which is conjugated to MMAE and is currently in development across solid tumors, including ovarian and endometrial cancers, which have a HER2 IHC of 1 or more. So now that we have many anti-HER2 agents, there is also a difficulty of developing resistance to these agents. There are various mechanisms, the first being modification or loss of the HER2 extracellular domains, which impairs the antibody binding to the receptor. There could be HER2 isoforms which can generate consecutively active homodimers, leading to the resistance. There could be mutations within the pro-survival downstream signaling pathway, like in the PIK3, AKT, and MAP kinase pathway. And there could be efflux of the HER2-bound antibody, leading to a mechanism of resistance. And there could be endosome recycling prior to the payload release, which may cause the drug to not act on the cell at all. So to conclude, I would say that HER2-directed therapies, they are a rapidly evolving area with the significant potential to advance the standard of care, and deeper understanding of mechanism resistance to HER2-directed therapy is crucial. Tumors from patients with recurrent gynecological cancer, they should undergo HER2 testing given the accelerated FDA approval of TDXD for previously treated recurrent 3+ solid tumors. And tumors from patients with advanced stage and recurrent uterine serous carcinoma should be tested for HER2. And it is reasonable to test more than one specimen, including at different time points, given the heterogeneity of HER2 IHC within the tumor across a primary and metastatic site, and as the evolution of HER2 IHC expression over time is not yet established. Thank you.
Thank you, ma'am. For panel discussion, we have moderator Dr. Sandeep Goyle. So please moderate the session. And we have a panelist, Dr. Amita Maheshwari, Dr. Anbarasan Sekar, and Dr. Jai Mehta.
Thank you very much. I'm Dr. Sandeep Goyle, Head Medical Oncology, Kokile and Durvaimani Hospital. And I would request my panelists, Dr. J is there. Wonderful talk, Jay. Thank you very much. Dr. Sekar again, good talk. And Dr. Amita Maheshwari. I think we are the only two ones who have not spoken so far, Amita.
Hi.
Right. So I think we have heard quite a bit about the theoretical aspects in endometrial cancer, the pathology, the role of immunotherapy, as well as the role of HER2 inhibitors. Now is the time, how do we utilize these information in our clinical practice? So I'm just going to share my slides. Just please hold on. Just one thing. Can you see my slides?
Not yet, Sandeep.
Okay, just 1 second. Let me just. Where is it? Just 1 second, please. Just 1 second. It is just, yeah. So share, Zoom, share. Can you see the slides now?
Yeah, they're visible now.
Yes, sir.
Yeah. Okay. Thank you. So this is more of the practical aspect as to what we have to do in our clinics, because sometimes the theory we're not able to practice in our clinics. So just a brief introduction of the case. 65-year-old lady with diabetes, hypertension, hypothyroidism, and present with abdominal discomfort and some diarrhea. On examination, found to have gross ascites and some hardness in the upper abdomen. And there was some nodularity on vaginal examination in the upper part of the vagina. Because of the diarrhea, she underwent a colonoscopy, did not show much, only some sigmoid diverticulitis. A CT scan done showed endometrial thickening, ometrial cake and ascites. And then I think biopsies were done. So they did endometrial biopsy, cytology, and ometrial biopsy. And all those suggested a high-grade serous carcinoma of the endometrium with metastasis to the omentum and ascites fluid. So, then the ISC was done, which showed high-grade serous carcinoma with all this molecular. Now, the most important point now with all the tumors is, and especially with endometrial cancer, is what molecular profiling to be done. And that's where let me ask Jay. Jay, what would you suggest to a clinician like me or Amita or Sekar as to what minimum requirement tests should be done on an endometrial biopsy specimen when we see a stage 4 endometrial carcinoma patient?
So if it's stage 4, I guess pole would be out, but then you would have to do at least the P53 and the MMR. In this case, HER2 as well, because it's a serous carcinoma. That's a fair call to do investigation for a HER2 as well. Maybe add a HRD beyond this if it's necessary, but to begin with, at least P53, MMR, and the HER2 for this case, the serous carcinoma high grade.
So Jay has suggested to us clinicians. So Dr. Sekar, what would you do if this was your case? What would you say? Would you send a full panel NGS, or would you do this basic test which Jay has mentioned? What is your practice?
Good evening, sir. Our practice is like we will check the IHC markers initially for P53 mutation and MMR status. And we will also offer a polymutation testing, but it is in the early setting. Early stage setting, we would have offered definitely for polymutation. And our panel for general patient is only 5,000. So we consider for early stage setting, and gradually we are incorporating into the advanced setting also. But still, it is not in a full-fledged setting. HER2 positivity, we second case-to-case basis. Why we tend to do early? Because we all know that the HER2 staining loss over a period of time. If it is HER2 staining has been done in couple of years back, then even if you check the sample again, repeat the testing, it may fade out. That is one reason we do HER2 testing in the baseline. Otherwise, it is not essential.
Not in the first
initial
setting,
staging,
that's what you say.
Not in a first line setting.
But Sekar, if suppose the HER2 comes positive in the first line, would you not like to add trastuzumab to chemotherapy? Or would you still go ahead with chemotherapy alone or chemo plus immuno?
No, sir. First line, we will add a trastuzumab. If it is positive, definitely we'll add a
So that is why it's very important for us to test HER2 in the first line, isn't it? Right. Amita, in your practice, now I'm talking about stage 4. We'll talk about early stage also, but in stage 4, what is your preference for doing molecular profiling?
So I think we already discussed, and apart from this, of course, it's a serous tumor, but we would, if had it been an endometrioid, we will also do ERPR, highly underrated thing. But we would do ERPR also, and we do have cases metastatic receptor positive after chemo, we use maintenance hormone therapy.
Right.
So,
Jay, is there any role of doing a full NGS in these patients, or like how we do for lung cancers and other colorectal cancers now? So in endometrial cancer, is that time arrived for doing a full NGS panel, or is this sufficient selected panel?
So listen, I mean, if there's a resource which permits you to do it, I would say do the entire panel, because you'll get a lot of information. You can get the HER2 amplifications there, the HRD out of it, the P53, you can get the MSI, the TMB, all of this information. But it all depends on the resource setting and the financial kind of, availability that, the patient has at its disposal to do that. So I mean, resource crunch things, you would like to do the basic things, but otherwise, yeah, NGS gives you a lot of information, including poll. In this case, it's not really indicated, but if you're doing the full panel NGS, you will get information on that as well.
So the reason why I asked you this question, Jay, is because in our clinical guidelines, whether is MSI high or MSI stable, whether it is P53 wild type or it is mutant, that the treatment doesn't change. It's more for prognosis. So you would still use the predictive value doesn't change, because you would still use paclitaxel. Maybe you can add pembrolizumab, or if HER2 is the only one. If it is positive, then you would add trastuzumab. So it's not going to change the management. So that is why, is it necessary? That's my only question. What do you say, Sekar? Would you prefer, or would you be happy with just doing basic? Because that's a very important question.
Sir, I'm happy with the basic. If IHC is done, it is good, and I'm happy with it. At present, NGS is not going to make much change into the treatment perspective. So I
yeah,
don't spend money in doing NGS.
Yeah, I agree. By and large, the only is a rare case of BRCA mutation.
Yes.
It's a serous tumor. So that may be the case where, we may like to do NGS.
So I think most of us would still agree that, a limited panel of these few testing is IHC and is required. As of now, we still not reached the stage of, doing full panel testing in endometrial cancer, at least. Right. And HER2, I think, is very important, because, if it is positive, we would definitely, at least I would definitely add trastuzumab to the chemotherapy backbone. Right. Coming on to, I know one important question, again, Jay is here, so we have to utilize Jay's knowledge. Jay, what about use of liquid biopsy endometrial cancer? Do you think it has a role right now or no?
No, I think not. I don't think we have much data to use that for endometrial cancers.
Right. So you would not use either upfront or even at a later date at disease progression. Would you use liquid biopsies?
I don't know.
Endometrial cancer.
Personal experiences, I don't know. We haven't had much success with those kind of things. Lung, yes. Colon, yes. But to be honest, sometimes pancreatic or biliary tract, but no. Gynec, I don't know. I haven't done many, to be very honest.
Because I think people are now recommending to liquid biopsies left at his center for all cancers, at least on disease progression. Amita, what do you think liquid biopsy role in endometrial cancer?
So I would say it's still experimental. We have not standardized as opposed to, say, lung or colorectal. So we don't use it.
Right. And Dr. Sekar, I think.
Sir, I agree with the other panelist also, sir. It is not standard. It is still evolving in endometrial cancer, at least.
So you would not even use it at a later stage on disease progression. Also, we would not be using liquid biopsies routinely in endometrial cancer, right? Okay. So I think that's very clear, because there's a clear message we need to give to the audience as well. So that's good. Now, coming on to this, we have discussed about this. Now, this biomarker testing which we are discussing, I think is more relevant for early stage, where you've got post sequencing, P53, and that's the decision regarding adjuvant therapy. So, Amita, how frequently do you do for all your patients now? Do you follow this protocol in early stage?
So we don't really follow this protocol, but we do for all patients poll, P53, MMR, IHC, and in addition, we are a fan of doing ERPR.
Right.
And the practical problem is, except poll, all are done by IHC. So reports are available much earlier than poll report. Poll takes 3 to 4 weeks to get the report. And
Right,
in
okay.
our, like, let me share our experience. So we, since we started doing also in our, this thing, pole is around 5%. MMR is around 29-30%. Around 25% are P53 and rest are NSMP. So that's our experience with around 170 consecutive patients where we have done this test.
And Amita, just one more question to you here only, that how will this impact your treatment decision making, you know, for pole positive,
So
for
if you are
P53
asking me as
testing?
a surgeon,
Yes,
not
please.
much. So I mean, how it changes a surgical decision? Currently, there is not really good evidence to suggest that based on molecular, although extent of surgery can be changed much.
Yeah, that's what I
Although
wanted to ask you.
we
Yeah.
prefer doing on endometrial biopsy, we generally do all these molecular on endometrial biopsy rather on the main specimen.
Yes.
One is, you know, tissue is well preserved and there is adequate tissue for doing molecular testing. But one scenario practical where we use, one is if it is P53 mutant and deep myometrial invasion, I would be very careful doing MIS for these patients. Although, you know, minimally invasive surgery, although, you know, international guidelines do not say it's contraindication, but there are some reports suggesting patients who are P53 abnormal and locally advanced stage disease, they have higher chances of relapse and poor overall survival when treated with minimally invasive surgery as opposed to open surgery. The second thing is I will also do more detailed lymphadenectomy if it is P53 abnormal. I will also do omental biopsy in these patients, omentectomy. And the other where, you know, we may do little bit is if it is MMR deficient, we do send them for genetic testing early. And if it is Lynch, of course, you know, rest of the thing. So that's how it changes a little bit.
So
and also, it has implication. We do see many patients, young patients, polycystic ovarian disease, where fertility preservation is required. There, molecular is very useful. We would do, you know, a medical treatment only for very early, well-differentiated, hormone receptor positive, P53 wild, not abnormal, and MMR proficient. These are the patients who would respond to hormone treatment. So there it is very important to have a molecular profile.
So again, if you have this data information on endometrial biopsy available, it will help you in some way or the other to decide your surgical, extent.
Right.
Am I correct?
Yeah. Right. So the other point is, if we have time, so ovarian preservation in a very young patient, endometrial cancer in select patient, we may do ovarian preservation, but we won't do ovarian preservation if it is P53 abnormal or MMR deficient. We know like MMR deficient tumors have higher risk for ovarian involvement also.
Right. And Dr. Sekar, in your now when Amit has done the surgery and the patient comes here for adjuvant therapy, how will this impact your adjuvant therapy decision making?
Sir, it has an impact because 2023 we are seeing this prognostic marker for the patients, and maybe we can in a selected group of patients be able to modify the treatment, especially in stage 1C where the endometrium and ovarian subgroup is there, where there is no indication for adjuvant treatment. That part we are, if the patient fits into the criteria, we are excluding. And apart from that, in selected patients, once the patient is elderly age group, otherwise they're having all the good factors. One risk factor is there, either P53 mutant or myometrial invasion is there. Then we see for polymutation in those subset of population, whether the poly is mutant or not. If poly is mutant, then we give radiotherapy alone, we omit chemotherapy in patients who are not borderline fitness for chemotherapy in those population. In metastatic setting, we all know that it has a major impact because in the
I think we have lost you. Dr. Sekar, we have lost you. Dr. Sekar?
Approval for dostarlimab pembrolizumab alone. It is we are yet to change in our routine practice for use of pembrolizumab in proficient MMR population.
Right. Okay. So I think in terms of this is more important for early stage rather than for metastatic. I feel that's why I feel.
Yeah,
Right.
just a point. Although
Yes,
for pole data is quite compelling, but we must remember there is no level 1 evidence to omit adjuvant treatment in pole mutant.
Yes, yes, yes.
So we are still waiting to have level 1 evidence. And I think it's a good practice to keep, do a poll and keep data on our patient so that we can correlate in future.
So I think still we are deciding our adjuvant treatment based on the clinical and the radiological staging and the surgical staging, rather than totally relying on the molecular markers. We can add the molecular markers information, but still I think the staging, surgical staging is most important when we decide the adjuvant therapy.
Right, but if you see European or American guidelines say even stage 2, like if there is cervical involvement also, and if it's a pole mutant tumor, you may omit any additional treatment.
Yes.
So which is we are not comfortable not doing anything to these patients. So although, I mean, in our series, pole is less than 5%, so we don't see so many pole mutants.
This is what, in fact, the data also suggests pole about 5 to 15%, deficient MMR 25-30%, P50 therapy again 5 to 15%, and NSMP 30 to 40%. This is what is the data from the molecular.
And other marker which we often do in these cases where we're not sure to give adjuvant or not is L1-CAM.
Right.
That's also IHC, and it has shown to have poorer prognosis in NSMP if L1-CAM is positive mutant type. So that has poorer prognosis. And we may are on the side of giving radiation to these patients.
So coming on back to stage 4 tumors now, let me ask Dr. Sekar. Sekar, what is your, do you differentiate in the first line setting of stage 4 endometrial cancer? Do you differentiate between deficient MMR and proficient MMR tumors, or do you give the same treatment?
And then we have to give in metastatic setting at least.
Dr. Sekar, आपकी आवाज ही नहीं आ रही है. वापस आपको रिपीट करना पड़ेगा.
Sir, in at least in metastatic setting, we need to differentiate because addition of immunotherapy has a more robust data in the deficient MMR population. With Ruby's trial, we have a 3-year data also, more mature data, which is suggesting for addition of immunotherapy in deficient MMR population.
But saying that, even if it's proficient MMR, you can still use paclitaxel, pembrolizumab, or you can use paclitaxel, dostarlimab. You can still use that. So why will it change? I mean, why do you? Would you not give in proficient MMR? Would you not give immunotherapy in combination with chemo in the first line setting?
The energy data 18 is compelling with which we are doing the suggesting for immunotherapy. But there are also certain criteria we need to choose the patient, because one important criteria is the patient should have a disease-free interval of 1 year duration in pembrolizumab. When we want to choose those patients, they selected those population. They excluded all form of carcinosarcoma or clear cell sarcoma histology from the energy 18 study.
Yes, exactly.
I think it's
So
more
these are
like
the
PARP inhibitors in
anyway,
HRD positive, like, niraparib, people say that you can give regardless, but we know the maximum benefit is only in patients who are,
yes,
I mean, just I'm giving a,
analogy, right?
yeah.
Right.
And also cost of immunotherapy and toxicity also we have to consider. So I don't know. Anbarasan, have we, are we using in MMR proficient patients?
That need to be more clear. And voice data is yet to come.
Again, Dr. Sekar, your voice is cracking. We can't hear you.
Sir, we need voice data. Whatever we are telling is based on the PFS data alone. And that is one reason why I'm asking to wait in proficient MMR population alone. And other thing is the percent of population. So we need a better biomarker to identify which group of population performs better with immunotherapy.
One more point here is in the first line setting, what's the role of bevacizumab in addition to chemotherapy? When you cannot, because Bev now is not very expensive these days. So if you're not using immunotherapy, if the HER2 negative, so can we use paclitaxel Bev, or do you think paclitaxel is only enough in the adjuvant setting, in the metastatic setting?
Sir, our practice is largely paclitaxel only. Bevacizumab we use case-to-case basis only. It depends, because most of the time patients are not affordable for bevacizumab. So our expertise is limited in this scenario.
Okay, that's fine. Okay. Coming on to, so you means overall, I'm not sure how much difference will be made, but yes, we would prefer to use immunotherapy, preferably in the deficient MMR population. But the problem is that that's only about 15 to 20% of population endometrial cancer, which is deficient MMR. About 80% will be proficient. So that means you're excluding immunotherapy in those 80% people. I think that has to be borne in mind, right? These are the factors which decide the treatment of endometrial cancer. And I think we have discussed all this, we don't need to discuss. Coming on to the second line treatment of endometrial cancer. Once you have, suppose you have used Paclitaxel, and how...
So just
what
a point before you go to
Yes.
second line, there is a role of surgery after chemotherapy if there is a very good response. Like we
Right.
treat, advanced stage endometrial cancer like advanced stage ovary. And we do assess them, and we have series of patients where we have done surgery after chemotherapy, neoadjuvant chemo kind of situation. Yeah, please go ahead with second line.
So, Amita, is that, for all patients you consider, or only a certain
So
criteria
all
fit in patients?
we review them after chemotherapy. Those who responds and surgery, disease is removable, we do offer them surgery.
Right. And
And
preferably, yeah.
surgery is generally open surgery, and the aim is like the way we treat advanced ovarian cancer, cytoreductive surgery, with the goal to remove as much as possible.
As much as possible, right? Okay, right. So I think that needs to be borne in
And the
mind.
other
That,
thing, why
yes,
we were not using immunotherapy in the first line pembrolizumab also, we not sure when the patient progress on Paclitaxel, after with second line pembro, whether the worst data will be mature, matlab will have a separation will be there or not. We have to yet to find out. That's why we are waiting for OS data to get into the picture, and then we can incorporate into our real world practice. That's also one more reason.
so you are more comfortable using immunotherapy in the second line setting, whether it's MMR proficient or MMR deficient case, doesn't make it, because there's data in the second line setting as well.
Deficient case, I'm very sure I want to use it in the first line setting. In a proficient case, still our practice is with chemotherapy only. And maybe in few selected cases, we consider immunotherapy in the first line setting.
Okay. So coming on to second line, how comfortable are you, Sekar, with using in MMR proficient tumors, lenvatinib and pembrolizumab? And what is your, what is the
In the
experience?
second, sir, in the second line setting, based on the platinum sensitivity, we have to see whether we want to use chemotherapy in the platinum setting, platinum refractory disease. But as a platinum refractory, still
We can't hear you very well, Sekar. Again, I can't. Is it me only who can't hear Sekar very well, or is it others also?
No, his voice is breaking.
Is very good.
Yeah.
If the disease-free interval is very good, then we consider for disease-free in the population.
Right.
If
Okay.
the disease-free interval is very less, then I consider the combination of pembro plus lenvatinib.
Fine. Okay.
Am I audible, sir?
Yeah, now you're audible. Now you're
Hello?
audible. Yeah, you're audible now.
Yeah.
Okay.
So based on the platinum sensitivity, I will decide upon the second line of treatment.
Right. Is your experience in lenvatinib? I find lenvatinib to be not a very easy drug to give. Any thoughts from either Amita or Sekar about lenvatinib usage?
Sir, our practice in general, we are starting at a little lower dosage, sir. Maybe 8 to 12 mg. Depends on the patient tolerance. And gradually we are trying to step it up, sir. So it's anywhere from 8 to 12 mg only patient used to tolerate.
Yeah, because I find we can't, there's a lot of urine proteinuria, skin rash, mouth ulcers, and
Diarrhea
fatigue.
is also one of the concerning factors.
Fatigue is a big problem, diarrhea as well. Right. There's one question on, when the patient is having a good clinical response, but the PET scan is showing disease progression on immunotherapy. So would you like to change the treatment, or would you think this is pseudo progression, or what, so anyone, either Amita or Sekar can take this.
Sir, there is a
Good
good
progression,
clinical
something
response
seen in
after
endometrial.
Hello. If
Yeah.
there is a good clinical response, at least for 6 weeks, and then I will repeat the PET scan again to see the response, whether the patient is truly responding or not. I will not jump in, change into the next line of treatment because we utilize chemotherapy as well as immunotherapy. The second line option is already brisk. So I give benefit of doubt for the patient. I will continue with the immunotherapy in such population.
Right, I think I agree. And just one more point, although we routinely don't do CA-125 in endometrial cancer patients, but in advanced stages, especially serous type, many times you may have CA-125 as a marker for response.
Yeah, I do quite routinely
Okay,
CA-125
okay.
in advanced endometrial cancer because
Right.
this is a good marker.
Yeah,
And I find and it's very reassuring for us to see if the market is going down.
right.
Then it's a good feeling that something is working for the patient. So I routinely use CA-125 marker, especially in serous carcinomas endometrium and at
And
stage.
some of endometrioid may even secrete CA-19.9. So
Right.
that's another marker. There's a question in the chat box asking about OS benefit from surgery. So I would say there is no level 1 evidence, but a general philosophy of treatment of endometrial advanced stage endometrial cancer is, if possible, do upfront surgery. If not possible, after chemotherapy, assess for surgery. And there is a benefit in terms of PFS. Definitely, I need to really check OS benefit. But of course, there's no level 1 evidence, no randomized trial.
Okay. So now this is the last question because we're already in 8:30. The Dr. Sekar presented good data, the DOE study. And so when would you think that data is, would you using it in your clinical practice now? Because none of the guidelines suggest that combination. So how do you put that data into clinical perspective at this stage in 2025? So let me ask first Dr. Sekar, then Dr. Amita.
Sir, there are several factors we need to see before using this combination because the grade 3 side effect with respect to the combination of Druva plus Olaparib is 70%. That is almost 2 out of 3 patients will present with grade 3 related side effect. And what they have shown is it is not a predefined subgroup. In NRG 18 was a pre-subgroup providing benefit. Study design, it is not a predefined subgroup. And also, other fact I would like to is there are certain groups which are shown definitely better improvement, especially patient with proficient MMR, patient who are having P53 mutation, patients who are having TAP score positivity. But I would like to ask Mehta sir whether TAP score has been done routinely in our scenario, or what is the kit we are using for TAP score, whether it is feasible in population or not. Maybe if all these factors are there, with a little more mature data, we may consider for it for our patients.
Jay?
Are you asking the TAP score for the PDL1 thing?
Yes, sir. TAP score for PDL1.
Yeah, so it is pretty much similar to the CPS score. So we do the CPS scoring as of now. TAP score, everybody's not doing it. It's admittedly slightly easier than CPS, but CPS is what everybody does right now.
But
is there a correlation between TAP score and CPS score, sir?
I'm sorry, say that again.
So do we have any correlation between TAP score and CPS score?
Not to the best of my knowledge, no.
Okay.
Right. So, Amita, would you, the data was presented, so would you be comfortable using this combination of maintenance therapy in your advanced stage patients, or what are your thoughts on the DOE data?
So, let me be honest, I send patient to Anbarasan and he decides. So even if I want, they won't give. So that's my take.
No, that understand. I just thought, because I think right now we need this data is DOE data, and especially in proficient MMR patients, there is showing some benefit of using it over durvalumab alone. So whether we should bring this into clinical practice or not, I'm not very sure right now.
Yeah, first of all, we are debating in MMRD whether we'll use durvalumab alone or not, right?
Right.
That's also debatable, and adding to Olaparib in that setting for us, to be honest, practically we don't use this combination.
Exactly. So even we have not used.
And also, sir, in proficient MMR population with respect to NRG study, I know it is not a cross trial comparison, not very good, but NRG 18, the median PFS in proficient MMR is 13 months.
And then duo is steady design. In profession MR, it is still 13 months only, 13.3 months. So if you do an indirect comparison also, it is not much significant. And GOG 209, which based on Pacley carbo is approved, there also it is 13 months. So that is also there. We need to see the reality of benefit. 1 or 2 months is there.
I don't think we have used this combination, right? Anuradha is also there. I don't think we have.
Right. Please, we can have her thoughts as well if she's there. Is she there?
No, ma'am. No, we've not used that combination till now.
Yeah, till now. And I think P value may be, but in what Anbarasan is saying in real life, I don't think that is really much gain.
I think that comes to the end of this panel discussion. I hope we have covered most of the points, if not all. If there are any burning points to be discussed, from regards to pathology, then please, Jay, you can very well speak now. And if any message to the, clinicians like us, please, what can the pathologist, what we need to do? So as clinicians to ask for pathology, you can just educate us.
No, I mean, pretty much, I guess all of you are aware. So would want to re-emphasize that what Dr. Amita actually said, that we should use these endometrial curatings for doing molecular testing. That's always a great way to go about it. MMR, yeah, that's we need to have proficiency testing to get these things going properly. And P53, while seems easy, it has to be properly evaluated by IHC. So you need to talk to your pathologist for all these things. But the rest, I think everybody is clued on now.
Hey, one more question here. Just I think Amita also can chip in this. Jay, quite a few non-surgical oncology gynecologists, they do endometrial biopsies. So do you think there's a difference, do we have to inform them as to what kind of sample needs to be taken for all the, because now molecular testing, they would not know about, what molecular testing needs to be done. And if you're going to do an endometrial biopsy, not the surgical specimen, then do you think it's going to be a different with whether a non-oncology gynecologist does or oncology gynecologist does?
I don't think there is actually much difference, but what is more important is properly preserving the tissue.
Right.
Once it's sent to pathology lab, I think we face a lot of issues at that level. Not the quantity of tissue, but quality of tissue, preservation of tissue, and the way it is processed at a general pathology lab. I think those points are important. What do you say, Dr. Chen?
No, I agree with you. I mean, if it's the tissue is not well fixed and you lost all that DNA integrity, and nothing much can be done beyond that. And as it is, when you get the specimen out, because it's there in the lumen, it really doesn't fix that well. So your best shot and the first shot is at the endometrial curatings.
Right. Okay. That's a valid point. Yeah, that's fine. So I think that brings to the end of this panel discussion. If any points need to be discussed, please raise it now. Otherwise, we'll hand over back to the organizers. Thank you very much.
Thank you so much.
Thank you.
Yeah.
Thank you, everybody. Thank you, Jay.
Thanks.
Thank you, Amita. And thank you, Sekar. Thank you. Yeah, back to the organizers, please.
Yeah, thank you everyone for your valuable insights. Thank you, sir, for excellent panel discussion. We'll have more collaboration together for future. Thank you. Have a good night.
Thank you. Good night. Good night. Thank you.